Yeah, so we'll be now starting. So very to all of you. Today's Webisode on GIST. We have planned to divide GIST into two sessions. One will be focusing on the role of targeted therapy in various settings, the overview and approach and the risk stratification of GIST. And the second will be focusing on the surgical aspects, the response assessments, and basically the neoadjuvant intent. So we have very eminent faculty today with us, and I'll introduce. We have Dr. Shyam Aggarwal sir with us, who is a very, very senior medical oncologist in Sir Gangaram Hospital, New Delhi. I think sir needs no introduction. So he has been a teacher, a mentor and guide, and he'll be delivering a lecture today on GIST and the context setting for overview, approach and targeted therapies. And then it will be followed by a panel discussion, which will be moderated by Dr. Sandeep Batra. He's a very senior oncologist, director of medical oncology in Max Super Specialty Hospital, Saket. And the panelist would be Sir himself, Dr. Shyam Aggarwal, and Dr. Priya Tiwari, who is a senior medical oncologist from Artemis Hospital, Gurugram. Dr. Avinash Upadhyay, who is a senior medical oncologist from Big Apollo Spectra Hospital, Patna. And Dr. Nitin Kumar, who is a senior surgical oncologist from Paras Hospital, Patna. So I welcome you all for this good academic discussion. And sir, you can share your screen and take over the stage for lecture.
So is it visible?
Yes, sir. Yes,
yeah,
visible,
absolutely.
sir. Visible. Yes.
So thank you very much, Dr. Shefali, for those nice words. So I'm supposed to be very, very senior, and Sandeep is very senior, and all others are, I think, senior. So great.
So don't go by words, sir.
Thank you very much for those kind words. Okay, so the subject today is, as Shefali has said, is a GIST overview. So I think I got a chance to review this after about 1 to 2 years, and interesting new developments have taken place in the understanding of particularly molecular biology and targeted drugs. Although some of these are not available to us, but I think it is better to stay in touch with the latest information and developments. So I think I can't move the slides, is it? Yeah, okay. So this is the background for gastrointestinal stromal tumors. And I think basically they are arising from the mesenchymal stem cell, and they used to call them interstitial cells of Cajal and cells from Orbeck's plexus and both neural and stromal features. So I think they are positive for c-KIT most of the times. I have another slide to this. CD34, 70%, and S100 and Desmin are usually negative. So I think that is the sort of little background, and the incidence is on the next slide, which states it's quite uncommon, as we all know. Males are a little more than females, and 5,000 cases per year in US. I don't know the number of patients in India, but must be around 1,000 or so per year. And these are the common sites: stomach, followed by small intestine, colon or rectum, esophagus, and then can also originate from extra, intestinal places like omentum, mesentery, or retroperitoneum. And I have a patient with prostate also. I don't know whether it makes sense, but then there are cases which can arise from other organs of the body as well. Okay, so this is usually these are sporadic, but I think there is an issue on the germline mutations, and there are, as you see here, this is a little old slide. Maybe there are more families who have GIST, and This is inherited as an autosomal dominant fashion since KIT and PDGFRA are located in the long arm of chromosome 4. And familial GIST has also been identified in families with mutations in exon 11, 13, 17, and PDGFR and exon 18. So there could be a case where there is a familial issue. Okay, so this is again continuing on the same this thing. So patients with neurofibromatosis type 1 who have KIT and PDGFRA genes, 8%, 6% mutated, can have GIST. And this is another rare carne triad where patients can have extraadrenal paraganglioma, chondroma in the lung, or multiple epithelioid GIST of the stomach. And these are related to the succinyl dehydrogenase enzyme mutations, which are either deletions mainly. So this is another issue which is been reported, and it is not very uncommon. You will see this. So this is what I was saying, that GISTs are usually positive for CD117, 95% cases. 70% will have, I think, the DOG or CD34 positivity, and smooth muscle actin is positive in 30 to 40%, 5% S100, and desmin 2%. So I think, that is the IHC marker expression in patients with GIST cases. So, okay, so this is another slide which tells you about the molecular subclassification of GIST, which is quite important to remember. So most of these mutations are there in KIT exon 11, which is 67%. KIT exon 9 is 8%. So which is important to remember because it has these have important connotations on the treatment front. PDGFRA is mutated in 10%. And as I said, SDH deficient is 10%. And now people have begun to identify BRAF mutations or NF1, as I told you, RAS, and other genes as well. So I think it is becoming important for us to do NGS to look at the cause of GIST, because the treatment with the TKIs is dependent on what mutation the patient's tumor is harboring and what is the driving mutation. So you can see 10 to 15% of GIST lack KIT or PDGFRA, so which is a fairly sizable number, and SDH deficiency is the most common there, as you see, 10%. So this is again, gastric is the commonest, followed by small bowel, followed by rectum. And this is the distribution of various mutations in stomach, small intestine. Again, 11 c-KIT mutation is the commonest in all. Rectum is the maximum. And then exon 9 is maximum again in rectum as opposed to gastric. And small bowel also has exon 9 mutation, which is present in 20 to 25%. So, the location of the tumor is also perhaps has a bearing on the incidence of various mutations present in the c-KIT or PDGFRA and other mutations. Okay, so just to showcase, we did a study in Gangaram Hospital where we did the mutation analysis of GIST cases. And we, although, sent more than 40 cases, but then we could, get the data only on 25 cases, and out of which 15 patients had, c-KIT mutation. Out of 15, 10 were in the exon 11, and the rest of the 5 patients, this is the distribution. You can go through the paper. That PDGFRA gene was mutated in 3 out of 25. And then we also found mutations in other genes like KRAS, AKT1, ERB2, BRAF, P10, and KDR genes. And after c-KIT, the most common mutation, the second mutation was TP53, so which was the second mutation in addition to the c-KIT. So 7 out of 25 patients had wild type GIST, and they did not have any mutation in KIT or PTGFRA. 4 out of these 7 patients had, as I said, KRAS and other. And we could not find any mutation in 3 patients because it was a 48 gene test. So SDH perhaps was not included in that NGS panel. So I think, as we all understand, that the main treatment for GIST is surgery, which depends upon the tumor size and the location and the operability. And once these, so I'm not going to the details of the treatment part, so as far as the surgery is concerned, but I think we thought I'll just cover the risk stratification, so which is dependent upon the size of the tumor, the mitotic index, and also location of the tumor, whether it is gastric or intestinal. So by and large, depending upon NIH or AFIP or modified NIH criteria, people have risk stratified them into very low, intermediate, or high risk. So the size of the tumor, especially if it is less than 5 and the mitotic index is less than 5, is taken as low or very low. So this is a bearing on the whether the patient should be given adjuvant treatment with Imatinib, because most of the guidelines suggest not to give treatment to low or very low risk stratified category patients. So similarly, if you look at the intestinal ones, the patients who have more than 5 centimeter or less than 5 mitotic index, so they come into the category of intermediate. So actually, you have to refer to a nomogram to figure out whether the patient is in a low risk category versus intermediate risk category or a high risk category. So I think for stomach, one can say if the tumor size is more than 5, or if the mitotic index is more than 5, well, they come in intermediate or high risk category. So there is a little debate happening even in the intermediate category as to is the benefit there. But I think my practice currently is to give treatment in the adjuvant setting where the tumor has been removed to patients in intermediate and high risk category. Okay, this is the presentation to just, from a center where there were a large number of patients. And as you can see, the 2-year, so it's a relatively indolent kind of a cancer. So 2-year recurrence rate is only 8%, and 5-year recurrence rate is 17%. So most patients, once you have operated and given them adjuvant therapy, are likely to get cured. And if you look at the mitotic index in these patients, so less than 5 is seen in 80%. So the aggressive behavior is seen in only about 20% of the cases. Rupture tumor is reported in about 8%. And a majority of the patients are, if you see here, less than 5 centimeter. 33 plus 40%, almost 75% patients are under 5 centimeter. This is a Western study. And gastric is the common 254 plus 138 non-gastric, which is the intestine or the rectum and other areas. So, by and large, GIST is a kind of a happy sort of a diagnosis because the cure rates, especially after the surgery, are very, very high. Okay, before I tell you the adjuvant treatment strategy, so this is what I was referring to, and this theme is going to be there again and again, that the PDGFRA mutations, if you find them, and most commonly in exon 18 and exon 12, they are, this particular, they're imatinib sensitive, but then if you have the D842V is unresponsive to imatinib and other, TKIs. This I've taken from 2018. The newer ones, you will find that this particular mutation is responsive to. Again, so exon 11 is the best of the lot, because it responds to imatinib standard dose, which is 400 milligram. But if you look at exon 9, there the sensitivity to imatinib is there, but then the dose has to go up to 800 milligrams, 400 milligram twice daily. Now, the other group, which is SDH deficient, there isn't any documented benefit from imatinib. So that is the importance of knowing that whether the patient has mutation in c-KIT11 or c-KIT exon 9 or PDGFRA, and which particular mutation is there. So that is the sensitivity and the molecular subtype. So I think this is what I was referring to, that patients who have PDGFRA exon 18 mutations, which are not sensitive to imatinib, including 842V. Avapritinib is the drug of choice over there. All others in the adjuvant and neoadjuvant setting are prescribed imatinib. So now coming to the results of the adjuvant imatinib. So I'll just focus on 1 versus 3 years of randomization to imatinib 400. And as you can see, the 5-year relapse-free survival, the hazard ratio is 0.6 and 71% versus 52%. So, that is the current guideline at this point in time. And as I said, patients with intermediate and high risk are usually subjected to this adjuvant therapy. Size of 5 centimeter or mitotic rate more than 5 per 50 high power field is the minimum criteria, or any sign of rupture. So there is a study going on to compare between 3 and 5 years of imatinib or 3 and 6 years. So I think the accrual is going on at this point in time, and therefore we are waiting for those results. So current guidelines indicate that we should be subjecting our patients, if they are in intermediate and high risk category, to give them 3 years of 400 milligram imatinib a day. Okay, so now coming to the advanced, which is the rest of the talk is going to be focused there. So you can see that 20 months versus 26 months for 400 to 600, and the median overall survival 57 versus 57 months. So therefore, on this data, 400 milligram once a day is the recommended dose. So neither 600 nor 800 improve the median overall survival. And the other drugs which we'll be coming to are sunitinib and regorafenib in 2nd and 3rd line respectively. And there again, there is a benefit, and therefore they are approved after the failure of imatinib in the metastatic or advanced GIST patients. Okay, so this is now again sort of a repetition. For all locations, one can have a KIT exon 11 or the RAS mutations, but in stomach, the PDGFRA you see pretty common, more than 90% of all the PDGFRAs, and SDH deficiency is seen more in stomach. And small intestine, you can see mutations in exon 9, 13, and 17, BRAF and NF1. So these are some tips to sort of remember as to what kind of mutations to expect. So I think this is a repetition of the same, that most of the mutations are in the KIT and PDGFRA, and the remaining GISTs that lack these drivers are resistant to TKI. So this is an interesting concept, which is worth knowing, that KIT and PDGFRA kinases contain an inhibitory switch and an activation loop switch. So because the drugs, the new drugs which we have, are sort of working on either activated or on the inactive type 1 and type 2. So this is how it is. I'll show you the next slide. So the type 1, which is avapritinib, binds to the active kinase conformation, and it is approved for advanced GIST. And the type 2, which binds to the inactive conformation of KIT or PDGFRA, which include drugs like imatinib, regorafenib, and sunitinib, are working on that aspect. So as a result, as you see, there are 5 TKIs: imatinib, sunitinib, regorafenib, which we have them, and avapritinib is for 842V mutation, and ripretinib is for other mutations as well. So this is another tumor agnostic gene abnormality, which is the NTRK gene fusions. So the incidence is 0.55%, and then these tumors are, then becoming amenable to Entrect or nerotectinib. So I think, as I said, first line treatment is dependent on the mutational status. So I think ideally, if you have a patient who requires for metastatic disease, then you should do the NGS because for exon 11 mutation, the standard dose is 400 milligram, and but 9 to 20% of GIST will have exon 9, and they'll require a higher dose, that is 800 milligram per day. So this is to show in exon 9 mutations, the data on 800 versus 400, and high dose, that is 42% more reduction or 31% reduction. And the overall response rates are superior with high dose than as compared to low dose. So only a KIT exon 9 mutation predicted a better outcome with high dose imatinib, and therefore 800 milligrams should be given to exon 9 mutation in the KIT. So these are the two drugs which are now approved abroad, ripretinib and avapritinib. So ripretinib is a broad spectrum KIT inhibitor and used in fourth line setting, and avapritinib is for KIT exon 17 and 842V, and is approved for GIST harboring PDGFRA exon 18 and 842V in the PDGFR. So 8% of GIST will have PDGFR exon 18 mutation, and account for 70% of PDGFR mutations and 5 to 10% of GIST. So now what is the data? That is the Navigator trial for avapritinib. And these are basically dose escalation studies and dose expansion studies. And the recommended dose is 300 milligram per day. And they divided them into various subgroups who were resistant to the previous TKI with KIT mutant GIST, or with PDGFRA mutant GIST, or patients with unresectable GIST. They were with or without 842V mutation. So let's see the data here, and 56 patients there. So you see, this is the for the treatment naive group, you see a complete response rate of 40% and a partial response rate of 60%. And this is for patients with the 842V population, whereas patients who were pre-treated, the response rates were a little lower than as compared to treatment naive. So this is an important landmark to sort of identify that these mutants, because they don't respond to imatinib or other TKIs, so avapritinib is the drug there. So these are some of the side effects like nausea, anemia, diarrhea. So we don't have the drug here, so I'll not go into the details of this, but there could also be some cognitive dysfunction and intracranial bleed in about 5%. But then, the drug can be stopped if somebody has cognitive dysfunction, and it can be restarted at a reduced dose with careful monitoring. So important to understand or remember that the drug should be kept in mind for the PDGFRA specific 842V mutation. So SDH deficient GIST, as I told you, about 10% of all GISTs. They can have germline mutations or epigenetic change resulting in hypermethylation. The problem is they're insensitive to imatinib, and we have very limited data with other drugs like sunitinib or regorafenib. So now, as you know, patients who are having advanced disease, cures are not possible, and most patients they eventually progress in about 2 years, and then they develop secondary KIT mutations in 90% of the cases. And they develop these mutations in exon 13, nearly 50-50, and exon 17. So this is how it is. And they differ among lesions or within tissue samples from a single tumor, thereby complicating treatment. So you can see here, these are the sunitinib is the second line treatment for patients who are developing mutations in exon 13 and exon 17 in the c-KIT as a secondary, as a result of failure from imatinib. So not a very good drug, but then it gives you a PFS of 6 to 9 months, and exon 13 mutations, they tend to do better for more than 3 years, and all patients ultimately progress as exon 17 mutations become more predominant. So these are the other areas where the mutations can develop, you know, and the PFS is 6 months or so. Regorafenib in the third line again gives you a PFS of about 4.8 months. So these are some of the other non-KIT, you know, resistant driving mutations, as you can see, TSC, P10, NF1, and so on. So there is a role for ctDNA as well. You know, I mean, you can pick up these mutations if your lab is, you know, has sort of standardized or validated these understanding of these or picking up these mutations. And this is can be used to monitor treatment response, like you've seen in lung cancer and colon cancer, etc. So there is a reduction in the mutant allele fraction when the treatment is given, for example, here with ripretinib, and it does correlate with the radiological and the patient response. So there's of course these unmet need here, because all these patients with advanced disease will progress. And so this is the fifth drug, ripretinib, which is, I told you the mechanism of action is to act on the activated tyrosine kinase. It inactivates it there. And this is a study which is still in progress, where they use the drug in the first line when the imatinib was intolerant, not that they were resistant. So ripretinib versus sunitinib is being compared. The data is not available, but what you have is the data. I think this is the regorafenib study, as I've already told you. I'll just skip this. So I think this is another study with avapritinib versus regorafenib, and not much difference between two drugs, and therefore it's sort of recommended as a fourth line treatment after regorafenib failure. So this is again to show that, but as I told you, for 842V, the drug of choice is avapritinib. So I'll skip this slide. So this is the study for ripretinib, where they compared in previously treated GIST patients, placebo versus ripretinib. And just to see the data here, the hazard ratio is very robust, 0.16 for PFS. And the median overall survival is also significant. So therefore, ripretinib in the Invictus study has shown its efficacy against placebo. And these are some of the side effects. So I'll not go into the details of this. So I think using multiple TKIs with complementary activity to target more resistant KIT mutations is a strategy being investigated. So people are also trying immunotherapy, etc. So there are, you know, combinations being attempted for various mutations. So I think this is theoretical. We need to just keep our sort of eyes open to these studies and the results. I think these are the combinations which are being used: ripretinib plus sunitinib plus binimetinib, and so on. So even the immune checkpoint inhibitors. So I think the summary is first line imatinib, sunitinib, regorafenib, ripretinib, and avapritinib. And this is first line for 842 PDGFR. I'll skip this in the interest of time. So this is a couple of slides in the end to showcase for advanced metastatic GIST. So I think you have to do the NGS mutation analysis to figure out what mutation is there, depending upon which avapritinib or imatinib would be used in the first line. And the dose of imatinib will be higher for exon 9 KIT mutation. So this is a busy slide, again, highlighting those points. And suffice it to say that patients who are responding and they become amenable to surgery, I think surgery has a huge, huge role to play, even in patients with advanced disease, when they have shrunk and have become operable. So I think don't forget surgery in even in recurrent cases. or patients you need to salvage them. And so I think this is all I would have to say. So I think the role of mutation analysis and the understanding of various drugs in different mutations has become critical to treat GIST patients properly. With this, I end here, and thank you very much for patient listening and inviting me.
Yeah. Thank you so much, sir, for a very, crisp, clear and summarization of all the good points. So there are few questions in the chat box, sir. So I'll be taking one by one. So the first question is there any data on cabozantinib and pazopanib in this setting?
Can we take that in panel discussion, Dr. Shefali?
Sure, sir. Okay. And the second is it necessary to do biopsy and check for change in mutations at each progression in metastatic GIST?
Again, so a typical panel-like question.
All right. So I'll leave these two questions for panel, and the third question from my side. So, sir, any thought on if there is a spillage or rupture during surgery and peritoneal cytology positive, otherwise having no metastatic disease, a low risk GIST? So, what is your take on this, sir? So for how long do we need to give adjuvant treatment? And
3 years. So currently the indication is 3 years.
All right. In ruptured also, we should not treat it as a metastatic, sir?
No, it becomes a high risk.
Okay.
You have to give adjuvant like for the other high risk.
All right.
It doesn't become metastatic.
All right. So I think
Dr. Shyam Aggarwal will agree with that.
Yeah, I think so. I agree.
Yes.
Right. So
I have a question, Dr. Fali.
Okay, Dr. Nikhil, please go ahead.
Thank you, Dr. Shyam, for such a wonderful presentation. And so do we do NGS in the adjuvant setting as well?
Yeah, so currently it is only Imatinib which is approved. So irrespective, so the point is that if you discover 842, I think the adjuvant Imatinib is not going to be effective. So the idea is to rule out patients for Imatinib if you find mutations which are not sensitive to Imatinib.
So, Dr. Nikhil, to add to what Shyam sir said is, though it is not a standard recommendation to do NGS in adjuvant setting, but if you have the finances and resources, and if you do it, there are two possibilities. One, you find a mutation like D842 in the PDGFR or STH, then probably these are the patients who will not benefit from Imatinib, so no use of giving Imatinib to these patients. Second, if you find a c-KIT mutation 9, then you can escalate the dose from 400 to 800 because it is shown in the adjuvant studies that these mutations respond better as far as PFS and OS is concerned with the higher doses than lower doses. So in a resource less country like ours, adjuvant Imatinib is the standard of care. But if NGS is done for whatsoever reason, then you have the additional advantage of decreasing the cost and toxicity of treatment by not giving adjuvant treatment to the patients with specific mutations.
Do we have this Avapritinib available in our country?
No, we don't have. Even if it was available, 35% incidence of cognitive dysfunction, though it reverses on withdrawal, but not complete reversal is there. So it's a very toxic drug. So even if it would be available, probably it will be for select few patients, and because most such patients with the GIST are between 65 or 75, that is 670K, and these are the patients who are more prone to have a cognitive dysfunction, and this drug causes a very high level of cognitive dysfunction not seen with other TKIs.
From a surgical perspective, like if we look at the mutational data in gastric GIST, 75% will be your standard KIT mutations and 10% will be PDFR mutation, which will be responding to this medication. So if you take off this, then probably NGS doesn't help much if you say this drug is not very useful or we cannot use because it's not available in our country. So even in neoadjuvant setting, the role of NGS becomes very, very limited.
So I would say neoadjuvant, it has more value than in the adjuvant setting.
Yeah.
So we'll be coming to that
in discussion. Available. See, 10% of the mutations are PDGFR, 75% is KIT, and rest 15% are other rare mutations. So if this drug is not available, then 10% of the patients cannot be given any neoadjuvant treatment.
No, I think it goes like this, Dr. Nikhil. The point is the drug can be made available. It must be very expensive. So I think patients who can afford, the NGS does have a meaning. And because Imatinib just doesn't work in a PDGFR, that 842 mutation. So, we are unnecessarily subjecting that patient to Imatinib or even to SDH mutants or deletions. So I think the understanding is, you can, if you have nothing, you can give Imatinib in the hope that patient might respond, but then at least in the beginning, and the patient also maybe can be told, we don't have the access to the drug, and the likelihood of your responding is very less. So I think that's how it is.
So NGS in the neoadjuvant setting will help surgeon more, Dr. Nikhil, because you will find out a patient who are not going to benefit from Metanip, and you will not leave these patients for a later surgery, especially when it is a borderline
so
thing.
My thought process, I was rather thinking aloud when I was asking that question, because see, in a NGS and plus the drugs which are not available in India, many of the patients obviously will not be able to afford getting a drug which is not available in India, getting it from outside. NGS, though, some of our patients can afford. So one of the way at looking at this problem is to start them on Imatinib and do a early PET-CT scan for response assessment. Maybe rather than doing a 3-monthly scan, we can do a scan at 4 weeks and see, or 6 weeks, we can see how it's going. And that will be probably more helpful than doing NGS. And anyway, we have to start the patient on something because NGS will take time.
So the other important information which you get is that if somebody has exon 9 mutation, then I like to give the higher dose. I'll not give 400 milligrams. So 15% of the patients are having exon 9 mutation. So getting information on a test, I don't think we should not be doing it. We should be doing it rather, so as to be wiser, so as to know the biology of the disease and the possible outcome. So I don't think we can stay blind for a few months and just say that we give a trial of Imatinib and then we will do a PET scan. So I don't agree with this concept.
Right. I think that's helpful. Okay, so no more questions, Dr. Shefali?
Yeah, so I think point well taken. We will move on to the panel discussion. So I would invite Dr. Sandeep Batra to moderate the panel, and all the panelists, Dr. Avinash Upadhyay, Dr. Priya, Dr. Nitin, and Shyam sir would be the panelists.
The standard question, the slide is visible.
Visible, but not in a full screen mode.
Full screen mode. Okay. Now it is in full screen.
Yeah,
right?
Yeah, it is in the full. Yes.
Okay. So thank you, Dr. Shyam sir, for that exhaustive lecture. I think most of the things that I wanted to ask in the panel have already been covered. Let's confront the clinicians with the clinical situations so as to put that information into the practical use. So I invite Dr. Shyam sir to stay back because Dr. Shefali told that sir will definitely stay in the panel. Dr. Anu Tiwari, she is a senior medical oncologist. Dr.
Priya Tiwari.
Dr. Priya Tiwari. What did I say?
Anu Tiwari.
Oh, sorry. She's at Kanpur. Sorry. Dr. Priya Tiwari, she's a senior medical oncologist. Dr. Nitin Kumar, he's a surgical oncologist, right? And
gastroenterologist.
Surgical gastroenterologist, GI surgeon. And Dr. Avinash, he is again a senior medical oncologist. So just usually do not have much role of radiation therapy. So Dr. Shefali has very beautifully not taken any radiation oncologists in the panel. I can see only Dr. Nitin and Dr. Shyam as my panelists. I cannot see Dr. Priya and Dr. Avinash in my panel.
Dr. Avinash is there and Dr. Priya is also there. Both of them are there.
Okay. So let's start with the, so this is the conventional slide of a small gastric cyst, which usually is not the case when it is found when it is symptomatic. Suppose someone does endoscopy for some unrelated problem and find these type of tumors that are a delight for a surgical gastroenterologist to take care of these tumors with the surgery. So I would start with Dr. Priya. Is the mutation testing required for all the patients? So Dr. Nikhil had some apprehensions to start with. So let's start with the first apprehension first. Dr. Priya, is it must for all patients to undergo mutation testing?
So I will be doing yes. I'll suggest yes.
All patients,
Yes,
even
sir.
if the patient was like such type of a tumor, less than 5 centimeters, incidental finding and very well taken care of with the surgery.
Okay, so I'll just change the statement. Wherever we feel that the systemic treatment is required in any
Wherever
particular setting.
So very early, small tumors, surgically resected, low mitosis, size less than 2 to 3 centimeters, not requiring any systemic treatment, we can not go for a NGS testing or mutation testing in such patients. Point well taken, Dr. Priya. So one learning for all these students which are there, not all patients require testing, only those patients which require systemic therapy in the neoadjuvant or adjuvant in the metastatic are the patients in which the testing should be done. Now, Dr. Nitin, I will come to you. Which are the compelling indications for going for an upfront surgery in GIST patients? I've given a slide of a gastric GIST, but these type of presentations can be seen in the rectal as well as small intestinal GIST. So which are the compelling indications for upfront surgery despite having an advanced non-metastatic GIST?
So generally upfront surgery is indicated whenever we don't require any multivisceral resections, even if the tumor is large enough and multiple visceral are not involved and multiple resection is not required, or in case of rectal GIST where sphincter involvement is not suspected. So in those cases, upfront surgery is generally indicated.
Are there any urgent or emergency indications for these surgeries?
So there are emergencies and conditions like if there is bleeding, sir, if there is perforation, in those cases, urgent surgery is needed, sir.
I think very rightly said. So despite patients having a non-metastatic advanced GIST, if you encounter a sudden hemorrhage, a torrential hemorrhage, a tumor rupture, a bowel obstruction, or a gastrointestinal perforation, these are all patients, despite being eligible for a pre-operative treatment, are the patients in which one is compelled to do a surgery. Now,
Sandeep, can I
sure,
ask
sir.
a question to the surgeons?
Yes, sir.
So, are there tumors where you can just do endoscopic resection depending upon the size or other parameters and not do an open surgery?
So tumors which are less than 2 centimeter, then endoscopic resections can be done. So 1 to 2 centimeter tumors. And laparoscopic surgeries for stomach cancers are commonly done now. If the size is less than 5 centimeters, generally recommended to do a laparoscopic surgery because only on greater curvature sleeve resection will be needed.
So to add on to that, by my understanding of staying with Nikhil and Asid, if the tumor, an endoscopic ultrasound is done and the tumor is arising from submucosal mucosa, not the propria, but muscularized mucosa, in which there is risk of perforation is not there if you do the endoscopic resection, then you can undergo endoscopic resection and don't require a full-fledged surgery. However, if it is arising from the muscularized propria, then probably endoscopic surgery is not justified, even if the tumor is small, because there is a real risk of perforation and the margins may not get the adequate margins. You agree with that, Dr. Nitin?
Sir, yes, sir, I'll agree.
Dr. Nikhil, you want to say something?
Yeah, size does matter. So as far as current understanding goes, despite like tumor arising from muscularis mucosa, you shouldn't do an endoscopic resection for larger tumors.
So smaller tumors, and if endoscopic ultrasound says that it is submucosally located and not deeply infiltrated, then probably. So Dr. Avinash, coming to you, this is a typical tumor which is very large size, and though it is upfront resectable, but the surgical colleagues thinks if you are able to cytoreduce its tumor, then the quantum of surgery will be less and probably the chances of a good resection will be there. So Dr. Avinash, so how will you proceed in such a patient? We have done the imaging, we have done the endoscopy, we have done the biopsy. Biopsy says it is a GIST. What are the things that you are going to proceed as far as further treatment or management is concerned? Just to give you an idea of what we are talking about.
So I would like to get the mutation testing done, because mutation testing will give us insight that how much dose of Imatinib is going to work, whether it's 400 or 800, or whether avapritinib is required or not. So mutation testing we will be doing, and based on the mutation testing, we can start the neoadjuvant therapy. Up 6 to 12 months of neoadjuvant therapy is generally required.
We will be coming to the duration that, Dr. Avinash, but what is the time taken for the mutation testing to return?
It almost takes 10 to 14 days almost.
So Dr. Priya, 10 to 14 days after the biopsy result is there, you have the imaging. Will you wait for the mutation test results to come, or you will start the treatment and modify based on the mutation testing results?
So I'll start.
Okay, so Dr. Priya, you have started, but unfortunately, after 14 days, the result has come back that tissue insufficient, which is a practical problem because these tumors are usually, they are prone to bleed. So someone did a biopsy, but was not able to take adequate sample. The IHC itself consumed the tissue, and after 14 days, you had already started treatment. The mutation testing is not available. So Dr. Avinash waited and you started, and both of you are now in trouble that what to do now. He doesn't have the tissue for testing, but did not start. You have started, but don't have the tissue now. Will you go for a repeat biopsy?
So in the best of scenario, that is what it should be done, because yes, the initial purpose of doing the biopsy to get the NGS result is not solved, isn't it? But we know that the GIST actually responds well, and the response can be seen very early.
So the
clinical decision making, clinical response is what is something that we can look forward to.
Okay, so are you saying that you will not go for a repeat biopsy? Should I understand from this that you are going to assess the tumor response?
Sir, yeah, I would say that I would want to do a repeat biopsy.
Repeat biopsy. Dr. Avinash, do you agree with Dr. Priya for going for a repeat biopsy?
We'll do a repeat biopsy, yeah.
Repeat biopsy.
But if the patient does not agree, a clinical response is something maybe I'll help to decide.
So the patient, if you counsel, depending upon your counseling, the patient can agree or disagree. Dr. Nikhil, now coming back to your question, with a country like us with poor resources, now Dr. Tiwari made a very prominent point that response assessment. So what is the test that you think a response assessment will tell us whether Imatinib is working or not? And suppose patient doesn't give a repeat consent for the biopsy.
If we are looking for early, you are asking me, right?
Yes, Dr. Nikhil.
Okay, I'm not on the panel, but right. If you are looking for early response assessment, then PET is the way to go.
PET is the way to go, and provided you did not have a PET in the baseline?
Do a PET in the baseline.
Do you get any information from CT also?
So see, there is RACIS criteria and there is PERSIST criteria, and we know from neoadjuvant setting that PET works very well as response assessment in GIST, and especially size reduction sometimes takes time. So if we want to know early response assessment, then PET is required.
So Dr. Shyam Aggarwal is widely agreeing with that.
Right. So that is fine. I wanted to make a philosophical comment to your other question in a resource constrained country.
Yes, sir. Yes, please go ahead. Sir.
I know we understand there is a resource constraint, but Google is available to everyone.
Mm-hmm.
So everybody knows who gets this disease. They'll Google and find out whether NGS has been done. They would know the importance of NGS. Even if they refuse, they know the importance of NGS. So therefore, it is imperative on our part to sort of, if initial NGS did not show any result, so we should tell them that, okay, if you get this information, well, then your treatment might change. I mean, if you don't want a biopsy, the onus should be on the patient. Once the patient doesn't respond, then the onus doesn't come to us. That is my point.
Okay. So, so that brings in the medico-legal issues, but coming back to the
question of medico-legal issue. So, you know, I mean, we don't have the other drugs available. The patients are on Imatinib in any case. There is a great chance of their responding. But then, yes, I mean, 80% response rate. But then, you know, 20% is not a small number either.
So, okay. So then
Nikhil wants to say something. Yeah.
Before Nikhil, I will point. I will. So,
sure.
Nikhil, you said doing a PET will give us more insight. So you said there are RACIS criteria, there are PERSIST criteria. There is something called Choice criteria also in the GIST, in which you see about the unidimensional decrease in the size versus a decrease in the density. They become more homogeneous as compared to the heterogeneity. So that's one of the way. Proof of taste of pudding is in eating it. So if your testing tells us that the tumor is responding radiologically, then probably even if the second opportunity for a biopsy is not there, if the tumor is already responding, irrespective of the mutation status, if subsequently on mutation you find on the testing you find a mutation which tells that it might be unresponsive, will you continue giving Imatinib, or you discontinue giving Imatinib because it was the mutation which was not supposed to be sensitive? So since it has already started showing response to the Imatinib, in the absence of a consent for second biopsy, you should continue giving the Imatinib, because as you said, 80 to 85% patients are having PDGFR and the c-KIT mutations, which are sensitive mutations. So continue giving that. So in the unlikely event of not getting a biopsy, we can reserve it for the surgery because you are giving this treatment in the neoadjuvant intent, and subsequently also you can get the mutations. So I will agree with Dr. Shyam sir, Nikhil and everyone that wherever possible, get a biopsy done for the mutation. But if you have already started with the treatment and you are devoid of a tissue for the further testing, and if you document there is a response, continue giving the treatment irrespective of the mutation status. So, now coming to the second question, Dr. Priya, do you order NGS upfront when you are planning a neoadjuvant treatment, or you go for a c-KIT followed by reflex testing of PDGFR followed by reflex testing for the STH?
Sir, so we do c-KIT and PDGFR analysis.
c-KIT and PDGFR analysis. Okay, Dr. Avinash?
Yes, sir. c-KIT and PDGFR.
c-KIT and PDGFR. So even we at our center are also doing the same. We have not adopted NGS upfront, but since the type of mutations which are coming up, because even in the c-KIT, in the PDGFR, you have one mutation which is sensitive, one which is not sensitive. So if you are doing an NGS, you probably get more information. However, the guidelines still suggest doing a reflex testing of the c-KIT PDGFR, and if they are negative, then going for the STH. This was for the understanding of the postgraduate students.
Sir, SDH anyways is going to be done by IHC only, right? Will it be picked up by NGS? I don't think
so. STH is not one particular mutation. They are insertions, deletions, homozygosity, etc., which cannot be picked only by the IHC. So all those tumors which are c-KIT and PDGFR negative, you have to subsequently send those tissues for the STH testing also. So
just a question here. So have you seen any SDH deficient tumor? I have yet not seen one. Anybody?
I have one.
So how are you treating that patient?
Actually,
resistance.
So one patient post multiple lines treatment, and when we, tried to plan cabozantinib because he progressed on whatever known treatment, sunitinib, regorafenib, everything he had. But by that time he had the brain met and which bled. So I could not start cabozantinib, unfortunately, but had planned for it. So that was the only single one I had.
So this gives me an opportunity, Dr. Shefali. Dr. VK had asked a question, data on cabozantinib and pazopanib in the GIST. So I think patients who have progressed on the multiple lines of treatment, and if there are no other options left, then probably you go for the cabozantinib and pazopanib. Is not that so?
Right, sir. Right.
So there are actually there are phase 2 trials for both cabozantinib as well as pazopanib. Yeah. The pazopanib, I think it got published in the Lancet also post sunitinib and imatinib and sunitinib. So they were responses.
Correct. So phase 2
trial is there for third line also, yes.
But cabozantinib is very difficult drug to tolerate. Very difficult.
Okay.
So SDH mutations do respond to temozolomide. We have seen one patient of SDH, and she responded very nicely to temozolomide. Actually, we came because he had this lymph nodes. He was a female, and the typical features of all the SDH mutation was present. We ordered SDH IHC. SDHB was negative actually, and then we treated her with temozolomide, and she responded nicely.
Okay.
Yeah, my patient also did well for a couple of months with temozolomide. He was post everything actually.
So coming back to the panel, Dr. Shefali. Dr. Avinash, do you typically see for the type of mutation when you are seeing a c-KIT or a PDGFR mutation report, or you just see c-KIT mutated, let's start with the Metanip, PDGFR mutated, let's start with the Metanip. Do you typically see which type of mutation is there?
We do see for c-KIT, we do see for exon 11, exon 9. Because these are the primary mutations. Secondary mutations will exon 13 and 17 in c-KIT. And PDGFR we do see for D842V.
Okay. And do you modify your treatment based on these mutations if you are starting something in the neoadjuvant setting?
Yes, sir.
You definitely do. Okay. So I think these all things were beautifully covered by Shyam sir. Let's continue with the panel. Coming to neoadjuvant TKI, because someone wanted more information. Dr. Ajay wanted more information about imatinib in the neoadjuvant setting. So we have already discussed this type of mutation does matter and everyone agrees to that. Which patients should not receive neoadjuvant imatinib? Dr. Nitin had already pointed out all those patients who require emergency surgery are not the candidates for neoadjuvant imatinib. Besides that, Dr. Priya, something comes to your mind based on the mutation testing that we have done, that these are the patients you should, if they are resectable, go for upfront resection rather than waiting for the imatinib to show its response.
So if the patient does not have any mutation in c-KIT or PDGFR that we commonly do, so like either the patient won't have any mutation or there will be like the resistant imatinib mutations.
Okay, so all these patients should not be offered neoadjuvant imatinib. If you offer imatinib, standard doses, you are using 400, 800, 600 or individualized
I start
doses.
with 400 for all exon 11. For exon 9, yes, the dose is higher. The starting dose is higher.
Have you analyzed your data of 11 versus 9 mutations? Because in the patients that I have not been able to see the exon 9 mutations yet. Dr. Shyam sir has got the vast experience. Sir, how many exon 11 versus 9? You showed your data about the 40 patients.
I showed you 10 out of 15 had exon 11 and the others were distributed. My point is regarding the treatment. So I think the message, take-home message for GIST is the primary treatment for GIST is surgery. So anyone who is considered inoperable by the surgeon, only then we should think in terms of any kind of neoadjuvant therapy. So the patient's primary treatment should be surgery.
So to just further qualify that, the only curative option of treatment is surgery. Wherever surgeon thinks upfront surgery is going to grossly encroach upon other organs, suppose it is rectum and their sphincter can be spared by using a neoadjuvant approach, then probably even in a resectable tumor, you can go for neoadjuvant treatment. But wherever surgery is a possibility without much disruption of the anatomy of other organs, surgery should be done, and we should not leave it to TKIs, even if they have a very strong data of showing a response. So now we have so one wonderful magic bullet, imatinib, which is going to be effective in almost about 80-85% patients. And now the question arises for the duration of the treatment, up before surgery, after surgery, and in the metastatic setting. Let's come to them one by one. This risk stratification is an easy one, easy to cram, I would say, and Dr. Shyam sir also showed in the presentation, and which categorically says any non-gastric GIST as compared to other gastric GIST are have more risk as compared to the other ones, despite the size and the mutations. Okay, so the first FDA approval for imatinib was without any time frame. It said adjuvant imatinib. It did not specify 1 year, 2 year, 3 year. It was the real world data that led to the final FDA saying of that 3 years of the treatment. So first trial, sir showed all the trials. So first trial, which was with the 1 year of the adjuvant imatinib, with all tumors which were more than 3 centimeter, relapse-free survival was significantly different, but there was no overall survival difference. Subsequently, 2 years of imatinib, again, in the high risk, there was a RFS difference, not an OIS difference. And finally, 3 years versus 1 year was high risk more than 10 centimeter or mitosis more than 10 or size more than 5 centimeter or a tumor rupture. Both RFS, relapse-free survival, and overall survival was improved at 5 and 10 years. So imatinib, 3 years is the standard, Dr. Priya and Dr. Avinash?
Yes, sir.
Okay. So I believe that if it is exon 9, you will obviously upscale the dose to 800 mg provided the tolerance. Any idea of increasing the duration to 5 years, Dr. Priya?
No, sir. I think there is some data people are doing because the thought process is maybe imatinib is just delaying the recurrences, so maybe increasing the dose. But yes, I don't have full clarity.
I think there is a trial going on, sir.
Yes, 5 years. Yes.
5 years versus 3 years. Problem is that even at 3 years, the discontinuation rate is almost 25%. So, and when it was increased to some like 5 years, the discontinuation became almost 49%. So that is also a problem actually. But they are comparing 5 years versus 3 years, and the results will be out soon. Imatinib in adjuvant setting.
So Dr. Priya rightly made a point: eradication versus tumor dormancy. With the Metanip, are we really eradicating, or we are only putting the tumor into dormancy? And since most of the recurrences happen within 6 to 12 months of withdrawal of the Imatinib, it is proposed that tumor goes into dormancy. So you need to continue, if the tolerance is there, to continue beyond 3 years also to improve the chances of survival. And Dr. Avinash was talking about this data, phase 2 trial, PERSIST 5 years, 100 patients, only 50% completed the 5 years. And there was a definitely improved survival, both RFS and UN, though it was a phase 2 trial. Now, these are all the trials for the neoadjuvant TKIs. So ultimately, finally came it as that 400 mg was the dose. Duration was finally fixed at the best response, starting from 4 weeks to 12 weeks to 24 weeks. And finally, it was continue till you have the best response, and average is 42 weeks, that is 10 to 12 months of treatment, and then take the patient for the surgery. Any discordance, Dr. Avinash, in this data?
No, sir.
Okay. Now the question is, you have given the patient neoadjuvant treatment and done the surgery. How will you decide about the adjuvant therapy?
Well, I would like to complete the 3 years. Like 1 year, we have already given, 2 more years will give.
2 more years. Will you quantify, I would say, patients based on the post surgery biopsy? The mitosis rate is low, the tumor size is less, and the location also. Will you take those criteria to find out the risk categorization of the patient, or you will simply continue if neoadjuvant diya tha to adjuvant bhi dena hi hai?
Was required, definitely size would have been vast actually. That's why we are giving neoadjuvant. So it's very unlikely that patient might not be a high risk candidate upfront.
Okay.
Size also is a criteria, right, for deciding the risk categorization. So if it's going to be a neoadjuvant therapy, definitely size would have been very large. Must be more than 10 centimeter. It must be more than 5 centimeter at least. So intermediate risk anyways is going to be.
Okay. So for the understanding of the postgraduates, if you have decided to give a patient neoadjuvant treatment, irrespective of the post-surgery Y pathological stage and the risk factor, you have to continue the adjuvant treatment to make it 3 years of treatment. So there is no clear-cut data about that, but going by the adjuvant trials, since the modification of the factors, tumor risk factors is there, you cannot change your treatment decision based on the post-operative histopathology findings. Coming to so we have covered the adjuvant, 3 years of treatment, better 5 years, but tolerance is not there. More data is needed, which is coming up. Neoadjuvant, all those patients who can undergo surgery should undergo surgery upfront. Those who cannot, start with the neoadjuvant, best possible response of 10 to 12 months, whichever is earlier, followed by surgery, followed by completion of 3 years complete of the total Imatinib treatment. Now, metastatic GIST. So this will be the last part. We are already in the fag end of the presentation. Now, Imatinib, again, 80% would have the mutation. So these are the patients going to respond. And here the role of the NGS becomes most important, I would say, so that you do not give an ineffective treatment for a resistant mutation. So Avapritinib not available, but as discussed earlier when Dr. Shyam also discussed his presentation, the cognition effect would make this wonderful drug a less tolerated drug. So probably may not come into the clinical practice much. Now there is another drug, Rivipritinib, and then Sunitinib and Regorafenib. But all these drugs are indicated once you have a failure of the Metanip. There are no patients who are upfront put on the Sunitinib or Regorafenib or Cabozantinib or Pazopanib or Pontanib, unless until the patient is intolerant to Imatinib or has not responded to Imatinib or has progressed on Imatinib. So this is the chart for the advanced metastatic GIST. You do a mutation analysis. If it is PDGFR exon 18 mutation D842V, which is not going to respond, there was 1 in 50 responses to some extent. So Avapritinib is the drug of choice. If they progress on Avapritinib, move on to Sunitinib, then Regorafenib, Ripretinib, and then clinical trial. In contrast, if patient has a classical c-KIT mutation or the PDGFR non-exon 18 mutation, start with Imatinib. If there is a response and resection of the residual disease is possible, resect the patient, resect the disease, and continue with the Imatinib till progression. So the dictum is till progression. There is no time duration of 1 year, 3 years, 5 years. You have to continue till progression, provided the tolerance is there. And once there is a failure, you can use Sunitinib, Regorafenib, Ripretinib, and then a clinical trial. please mind it, ripretinib is only given for the patients who have failed on imatinib, sunitinib, regorafenib, and if it is D840 mutated avapritinib. Upfront, there is no data of ripretinib after or in place of the imatinib. So since we have already exhausted time, 8 minutes more, so I will be happy to take questions to be discussed with the panelists.
Yeah, sir, you can see the chat box and you can take up the questions.
Okay.
Sandeep, can I?
Yes, sir.
He has used radiotherapy in a patient with failure on imatinib and maybe even sunitinib.
No, sir, yet not.
I can narrate one instance of a patient who was operated for gastric cyst and then was given 3 years of imatinib. We stopped it, and after 6 months, she relapsed locally, I believe, in the skin, in the subcutaneous tissue. So since it was a localized relapse, we requested the surgeon to remove the tumor, and resection was done, but the margins were not clear, sorry. So the margins were positive. So, well, I referred, and the Ki-67 was 50%. So I had that dilemma of, do what? I referred to the radiation and they accepted.
Okay, sir.
How was the response, sir? How was the response?
So there were only margins were involved. So there was no disease, seen. So patient finished the radiation, I believe, a month ago. So we'll reassess and maybe we'll put her on some drug depending upon the NGS.
I would want to just add one point here. I mean, re-resection is not advisable for margin positive cysts. Even if we resect and if we find that margins are positive and if surgically resectable, we don't do re-resection. We'll just give adjuvant and hope for the best. And if it comes again, probably at that time we'll resect.
Yeah, so one more question, sir. Now in this setting, it's not a proper adjuvant. So for how long will you continue the drug in this setting, and which drug would you choose? Again, NGS or something?
Yeah, I think ideally we should do the NGS, and depending upon the mutation, because as I said, there was a 6 months gap from stopping the imatinib. So I might stick on to imatinib again, and give it virtually for a long period of time. So which could be undefined at this time. And since we have given radiation also, so at least for 3 years, I guess, if she stays in remission, then we can think of stopping it. But these are, you have to individualize, I guess. So you may not get a straight evidence-based answers.
So,
right.
Dr. Roshni had asked, biopsy required at each progression? I don't think so. Biopsy is required at each progression because you have the diagnosis. And if you have a patient who has had a treatment started 5 years, 7 years back, then it will be a good idea to go for a biopsy for the sake of NGS, because you can have development of the new mutations, which can give you more insight of the type of the treatment. We have another question from Dr. Gagandeep, who says limited molecular panel requires 30,000. How much full NGS? Dr. Gagandeep, jitna good daloge, utna meetha aayega. So if the cost is not an issue, you can go for something like NGS from the foundation one, or which is 420 genes, and something like Claris, about 550 genes. More the number of genes, more the mutation panel, more is the cost. Then he also asked, what about good thin cut CT scan for response assessment? So a CT scan, provided it can give you the size estimation of decrease in one longitudinal dimension or decrease the density, which is measured with the Hounsfield units, you can very well go for a thin cut CT scan to find out the response to imatinib if you don't have the reports available for the tissue or the NGS. I think that answers the question. 3 and 5 questions we have answered. Any other question left, Dr. Shefali?
No, I don't see any other questions. Dr. Nikhil, any questions from your side or anyone else if have?
Grateful one.
I
just want to say one more thing. That
yes, sir.
I think there was a study which was conducted way back where they biopsied, different sites in the liver, and it was very interesting to note that different mutations were found in the same patient at different sites. So as the disease becomes more and more chronic and it evolves into patients with different mutations, and therefore you do not get similar response at all the sites. So I think those are interesting biological considerations for any malignant disorder, including GIST.
Yeah. So I think it's worth doing a rebiopsy if, like sir said, every other site except for one or two sites which are not responding at all to your treatment. So I think to see for the resistant mutation to imatinib, if somebody can have that. So that is one indication.
So another question has come up from Dr. Gagan. How many cases do you see in Delhi who don't go for NGS? The number will be limited, but anyone who has progressed on the 2 or more TKIs, usually if counseled well, then go for the NGS. Unfortunately, we don't have trials in Delhi NCR running for this particular category of tumor. Another question is from Dr. Devinder. Any role or scope of liquid biopsy in metastatic GIST? If patient is not willing for rebiopsy or tumor is inaccessible. Dr. Shyam sir in his presentation had showed the data for the liquid biopsy. Since it works on the circulating tumor cells, yes, if the tumor is inaccessible or biopsy patient is not willing, then you go for the liquid biopsy. But if you do not get anything in the liquid biopsy, then the gold standard will still come back to the solid part, that is the tissue. So if you get something in the liquid biopsy, you can defer the biopsy of the tissue. But getting nothing in the liquid biopsy, it becomes mandatory for you to counsel and send the tumor for the testing.
Yeah. So I think we have covered exhaustively GIST. So next session we'll be covering the surgical aspects and assessment of response for that. And it will be on the first Wednesday of next month. So we'll be posting the details soon. Thank you so much. Thank you so much, sir. And thank you so much, everyone, for contributing your time. Thank you.
Thank you, Shivali. Thank you, Shyam sir. Thank you, Dr. Priya, Dr. Avinash, Dr. Nitin, and Dr. Nitin. Thank you, everyone.
Thank you, everybody.
Okay. Good night.